We'll get started in our presentation, which is Suicide Prevention Safety Planning, a systems approach to evidence-based practice in the crisis care continuum. So, of course, we will start off with a disclaimer. We are very grateful for the funding that we receive from the Department of Healthcare Services. What I'm about to say does not necessarily represent DHCS or the agency that I am employed by, which is the Center for Applied Research Solutions, CARS. So if you're new to CARE, we are the Crisis and Recovery Enhancement Training and Technical Assistance Center. We are funded by DHCS through MHSA funding, Mental Health Services Act funding, to provide training and technical assistance to the mental health workforce along the crisis continuum of care and justice diversion in the state of California. We predominantly work with MHSA funded county programs, behavioral programs mostly across the state. We also work with nonprofit agencies that are in the community, and we are thrilled to have a really robust team. We work with the Recovery International, you might know of them as RI, the National Association of Mental Illness California chapter, C4 Innovations, Research and Action Center at Impact Justice, and Stanford Youth Solutions. We provide a variety of services, training and technical assistance, as I mentioned. If you are interested, please do go to our website. We'll provide the link at the end of these slides, and you can make a formal TA request. But in addition to providing TA services, we also have distance learning like this session today. We have a variety of tools that are in our resource library, also on our website. And we are going to be rolling out some regional trainings. And we have a variety of other resources, including a newsletter that comes out on a quarterly basis. And we're going to be doing some fun things with social media. You are joining us at really the beginning of our 3-year project. And so we are right now in the process of learning from the community what your needs and interests are. And we're doing that through a needs assessment and a variety of listening sessions. At the end of the year, we will have an annual conference. And all of the materials that we create, the lessons, distance learning, as well as these learning collaboratives and other resources to the field are going to be driven by what you tell us you're interested in. So please do complete our needs assessment. It only takes a few minutes and you can enter your name to win a raffle card for Amazon. Additionally, we do have those listening sessions that I mentioned, which are coming up as well. If you're interested to learn more about any of this, please visit our website or send us an email. A little bit about me. My name is Eliana. I've worked on suicide prevention for a variety of years with many communities. Most recently, I have worked at the Veterans Affairs Hospital, where I worked especially with LGBTQ veterans doing suicide prevention, and also veterans who are living with complex unexplained medical illnesses that are related to exposures from their combat history. But I've also engaged in LGBTQ suicide prevention, and I've done suicide prevention with homeless youth and youth on the Thanaatham Reservation in southwestern Arizona. So I'm really excited to be with you here today. This is an incredibly important topic and very timely, of course, given the many stressors that are going on in 2020, including the global pandemic and the recession that is befalling us in the United States. So today we're going to talk about first some suicide statistics, and then we're going to go into statistics around COVID-19 and how those two might intercept, especially for communities of color. Then we're going to talk about the crisis continuum and how suicide prevention fits into that from a systemic view, really drawing from both SAMHSA's national guidelines, as well as a 2020-2025 suicide prevention strategic plan from the state of California. Both of these docs are essentially hot off the presses. And so we'll be contextualizing safety planning within a systems approach vis-a-vis that national and state level directive. Then we're going to talk about evidence-based suicide prevention and locate it within our current situation of social distancing. We're going to talk about telehealth, suicide prevention tips. Then we'll go directly into risk assessment, safety planning, and means restriction as 3 key evidence-based practices. And I'm super excited that we're actually going to do a role play with you. Or for you. I'm going to be joined by my esteemed colleague, Ms. Tiara Peterkin, LCSW, who is the program manager for the CARE TA Center and a former suicide prevention coordinator, actually also for the Veterans Affairs Hospital. So the two of us are actually going to act out for you a suicide safety plan that's based on culturally relevant perspective. And then we're going to go into culturally responsive, community defined, and socially distant suicide prevention. And I just want to give you a heads up. All of the links that are in these slides that you're about to see have been placed into a resource guide, which you have available to you. It was sent ahead of this presentation, and we will also send it again with a follow-up email. I do want to encourage people to please use the comment chat box if there's something that you'd like to share. We do ask that you use I statements and that you're thoughtful about the language that you use. We strive to be anti-stigmatizing in the language that we use. And we recognize that this topic can be really challenging for folks. Please do reach out if you would like to receive support. We have the National Crisis Hotline listed here, as well as a COVID-19 crisis hotline. To the extent possible, we encourage people to not multitask with a cell phone or other things. We know it's hard in 2020, but this topic is really important, and it oftentimes will require us to have our full attention. So we're going to start off with a webinar poll, a couple of them. We'd like to get to know you. So the first question to get to know you all is, what type of job do you do? I know some of us have had multiple professions in our lives, but just right now, what kind of work are you doing? Are you a social worker, a psychologist, a marriage and family therapist, a peer specialist, school mental health provider, program administrator, or other? Okay, so we've got a good proportion of social workers, followed by school mental health providers. Welcome. I'm so glad to have all of you here. Program administrators, marriage and family therapists, excellent, and social and psychologists as well. And then a variety of people who are outside of those categories. I've seen a lot of people in the chat box who are entering SUD counselor, case manager, housing navigator. Excellent. I'm so glad to have all of you here, because from a systems perspective with suicide prevention effectively takes all of us, and it takes all of us in coordination with one another. Next question is, does your agency have a suicide prevention protocol for the COVID-19 pandemic? For example, a plan for who conducts suicide assessments, which assessment tools to use, and what to do if suicide risk is identified. Your answer choices are yes, no, don't know, or NA, not applicable. So does your agency have a suicide prevention protocol for the COVID-19 pandemic? Meaning, if you're in an agency that has the doors closed during social distancing orders and everyone is working remotely, is there a suicide protocol that's in place for that particular environment? If you are lucky enough to be in an agency where the doors stay open, even when there's social distancing happening, but there are changes that happen elsewhere, like our ERs might be overly impacted. Does the protocol, if your agency have one, meet those needs? So here are the responses that we see. 64% of you said yes, wonderful. 30% of you said don't know. That's really common. 4% said no, and 2% said not applicable. So as you could tell from that previous question, we're really wanting to locate this within COVID-19 and as well as a systems perspective of crisis care continuum. So this next question is, does your county have a mobile crisis unit? Your answers are yes, no, or don't know. Mobile crisis units are an evidence-based practice as well for a variety of mental health crises, often for suicide prevention. And importantly, they can be called as an alternative to 911, which is really important, of course. Police officers are not the best suited to engage in mental health crises. And for many of our communities, especially Black community and Latinx community, engagement with police can sometimes be lethal. So the response is here, 61% of you said that, yes, your county does have a mobile crisis unit. 11% said no, and 28% said don't know. Okay, thank you. Well, in a few minutes, I'm going to be sharing with you some important places where you can find out these kinds of answers. Next question, does your county have a brief psychiatric stabilization unit? Answers are yes, no, or don't know. And they might be called a couple of different things, but essentially what this resource does is it provides a place for people to go as an alternative to the emergency room. We know that especially with suicide, when people go to an emergency room, they are oftentimes surrounded by a lot of hectic chaos that's going on. People in physical health emergencies, staff running by up and down, left and right. They oftentimes are not stabilized in that kind of an environment because it's so stressful. And secondly, oftentimes there's not actually any intervention to address the suicidality in the first place. And we know that it's very costly, and it's also not the most humane place for people to go when they're feeling overwhelmed. What's the response rate, please, to this one? We'll see it in just a second. 69%. Wow, 69% of you said that your county does have a brief psychiatric stabilization unit. 7% said no, and 24% said don't know. So as I mentioned before, we strive to use non-stigmatizing language. What that means in particular, when we think about suicide prevention, is that we use people first language. So we talk about people who have died by suicide. We don't use terms like suicide victim, suicide contemplator, or suicide attempter. Those terms can be stigmatizing to people. Additionally, we would use person first. We put the person before the behavior, person thinking about suicide, or people who have experienced a suicide attempt. Again, we stay away from terms like committed, successful, completed, failure, because these terms suggest a value that we would not want to put onto this experience of distress. So briefly, I'm going to just kind of give an overview. Many of you might know this information already, but just to share importantly that suicide is very prevalent in the United States, and it's extremely costly as well. We do see differences in populations. We see in general that men die by suicide at 3.65 times more often than women. However, importantly, women attempt suicide at 1.4 times more often than men. White men account for 69%, almost 70% of suicide deaths. But as you'll see in a few slides, there are some really significant racial disparities when we start to look at specific populations like youth, as well as LGBTQ folks. And firearms account for 51% of all suicide deaths. One of the main evidence-based practices for suicide prevention, of course, is means restriction. And part of it has everything to do with the lethality of the means. And firearms are one of the most lethal means that are out there. So some of you might be aware of the very exciting work of the Mental Health Services Office of Accountability Commission. They put together a strategic plan for California from 2020 to 2025. It's called Striving for Zero, California Strategic Plan. And what they found from a variety of listening sessions across the state, looking at the data that's available, as well as the literature, was that while California's suicide rate is lower from the 2017 data than the national rate, when we start to look at certain communities and demographics, that rate actually goes much higher than the national average. We see that for the most common method for suicide attempt in California in 2017 was drug overdose, but the most common means for death was actually firearms. We learned that suicide prevention is most effective when we use culture-specific interventions. So that means tailoring things like the safety plan, what I'm about to show you in a little bit, to the culturally specific experiences of the client that you're working with or the consumer that you're working with. So when I say that, I mean things like, from that person's cultural perspective, what are major stressors that might lead to somebody to feel so overwhelmed that they see no other option for themselves in that moment other than death? How does that person's culture think about suicide as a choice that somebody could make? Additionally, and this is something that I feel very strongly about, is what are the culturally specific strengths and resiliencies of our clients and the communities and families they come from that can be used to supplement or apply to our suicide prevention safety planning. And importantly, we know that including the experiences of people who have experienced suicidal ideation or suicide attempts and people who have lost loved ones to suicide, having them involved in the planning of our services is absolutely essential. And for example, peer specialists can provide a level of support, hope for recovery that is hard to come by in any other type of profession or discipline, because their very lived experience shows somebody who's in a suicidal crisis that things can and do get better. Additionally, we know that when we have separated and uncoordinated systems, so for example, when we have a mental health clinic that sees a client who's in suicidal crisis, who does not communicate with an emergency room, and the emergency room does not communicate back to the community mental health center when the person is discharged, that's when we can have some really significant missed factors with uniform screening, and assessment for suicide. So we want to make sure that we have our systems speaking to one another and following clients through each level of the crisis continuum of care. And we know that underutilized prevention interventions that have already been established as really helpful are significant still to this day in California and many places across the nation. But we really want to focus on things like building bridge barriers, locking railway doors and windows in hotels or hospitals that are at lethal heights, and especially also safe gun storage. MHSOAC found through their suicide prevention research that led into this strategic plan that there are some new and novel prevention interventions that are being done in California, which are really exciting. We're seeing in schools an increase in mental health services, as well as training and education on social emotional learning. These are skill sets that will help students not only in their youth and young adult lives, but throughout the course of their lives to deal with challenges in a way that is based from a place of resilience. We also see an increased attention to workplace well-being within businesses. And one example is through employee assistance programs. We see gun stores who are being engaged as critical sites for suicide prevention efforts and talking about how I think they're called, it's not guidelines, but there's like a bill, there's a term that is used within the gun community that talks about kind of the major values of gun ownership. So there are things like keeping the guns clean and functioning properly, and using the safety lock, and going to gun ranges. So it's essentially about responsible use of guns. Adding to that list, suicide prevention messages like the crisis line number is another way that we are starting to engage in very novel and new prevention interventions engagements. And then, as I mentioned before, developing suicide prevention that is based on culturally informed stressors and strengths. So importantly, the Striving for Zero Suicide Prevention Strategic Plan for the state of California calls for uniform policies and practices that include safety planning. And that's really, again, why we want to locate what we're doing today within this larger strategic plan. So we've got another 2 polling questions. We'll do the polling questions. These are myths and facts. So we will ask you true or false. First question is, most suicides are impulsive and happen without warning. True or false? The response is 94% said false. That is correct. In fact, over 70% of people who die by suicide communicated to someone their plans for the attempt prior to their death. Most suicides are preceded by warning signs, such as communicating the desire to die, having no reason to live, or feeling like they are a burden. So this is another true or false. The question is, people who want to die are determined and there's no changing their minds. True or false, please? 95%. Ooh, you are on point, people. That's exactly right. False. Over 90% of people who were interrupted in a suicide attempt will not go on to die by suicide at another location or by other methods. Research suggests that those at risk for suicide often show extreme ambivalence. So they feel one way and another way simultaneously about the desire to live or die, and express a high degree of suffering. The accounts of attempt survivors suggest that many people are relieved to have lived through an attempt and regained their desire to live. This fact highlights the opportunity to intervene and separate the person at risk from lethal means for a suicide attempt. Communicating about suicide will plant the seed of, and then thank you. So that is the reason why what we are about to talk about with safety planning, with means restriction, it really can make a difference. So some of this might be familiar to you, so I will kind of fly through a little bit of it. It's important to note that there are racial disparities with suicide. This is data from 2018. Past year thoughts, we see highest rate of thoughts from people who identified as American Indian and Alaskan Native, followed by people who are white. In terms of attempts, We see the highest rate of attempts from people who identify as American Indian, Alaskan Native, and followed next by people who identify as Black. So we see continued disparities when we look at diverse populations. We see higher rates of suicide among the veteran population as compared to the non-veteran civilian adult population. When we look at youth populations, we see higher rates of suicide plans among female youth as opposed to male youth. We see the highest rates among Black and then followed by Hispanic and then followed by white female youth. When we look at the male population of youth, we see the highest rates of planning among Hispanic, followed by white and then Black. When we look at sexual orientation, gay, lesbian, and bisexual youth have a 38% rate from the 2017 Youth Risk Behavioral Surveillance data. 38% of gay, lesbian, and bisexual youth had made a plan for suicide compared to 10% of heterosexual youth. When we look at actual suicide attempts among youth, we see, again, disproportionate levels. For females, we see the highest rate of attempts among Black females, followed by Hispanic and then white. And then we see, with looking at the the male population, the highest rates among Black males, then followed by Hispanic and then white males. And I want to point out, we saw this in the last slide as well, that while young Black men and Black adult men are not showing up at the higher levels for the plans, we are seeing higher levels of actual attempts. When we look again at gay, lesbian, bisexual youth, 23% had made a suicide attempt in the past year in 2017. 14% of those youth who said they were not sure what their sexual orientation was had made an attempt, and compared to 5.4% of heterosexual youth. It's really important when we think about COVID-19 and people sheltering in place at home, that 1/3 of LGBTQ youth who are sheltering at home with unsupportive family members have an 8 times higher risk of suicide than other LGBTQ youth who are sheltering at home with family members who are supportive of them. Really good news, however, is just one person in an LGBTQ youth's life can reduce the risk of suicide by 30%. If you could be that one person in an LGBTQ youth's life, you could make a major difference. So it's important for us to think again about racial disparities when we start to look at COVID-19, because we are seeing higher rates of infection and higher rates of mortality among communities of color. You might be familiar with some of this information, but race it's a social category. There are no biological differences between races resulting in COVID-19 disparities, but rather there are differences in socioeconomic status. There are different differences in weathering. That's the experience of having chronic stress over a lifetime that makes a body predisposed to higher rates of illness. So we see higher rates of diabetes. We see high rates of heart disease in Native American communities, Black communities, Hispanic, Latino communities, Latinx communities. And when people who have those pre-existing conditions are then infected with COVID-19, that's when we also see higher rates of mortality. When we talk about SES, socioeconomic status, we see that people of color and folks who are low income are tending to work in jobs that are that do not have the privilege of working remotely. So these are people who are driving for Uber. They're cleaning hospitals. They're working in grocery stores. These are jobs that are staying open even when everyone else is sheltering in place. But additionally, when we think about SES, we look at communities that are inner city, that are a lot of people living right next to each other, so it's harder to do social distancing, or looking at families that have multiple generations within one house, or perhaps we're talking about a reservation or other communities where there is not access to clean water. So people are not even able to do the hand washing hygiene that's recommended to prevent infection. So people start to wonder, well, what are the potential rates of suicide with COVID-19? Well, first and foremost, we don't know yet. Just the way that data is collected with suicide, there's always a bit of a delay. But here's what we're seeing, some kind of other variables that might lead into something that might help us to kind of paint a picture. In Cleveland, Ohio, at one point earlier on in the summer, there was actually a reduction in people who were showing up to ERs with suicide-related thoughts and behaviors. Now, that could be that people were avoiding emergency rooms because they were scared of potentially coming into contact with somebody who was infected with COVID. We did see, however, increased calls to crisis lines from the beginning of the pandemic till now. We have seen with 2003 SARS, as well as the 1918 flu pandemic, there were increased suicides, especially at a certain point among elderly people. We're seeing that there are projected deaths of despair with alcohol and drug use and suicidal ideation when combined with COVID-19. So the projected deaths of despair are saying when we think about the recession, people losing their jobs, when we think about COVID-19 and actually being infected or losing family members or loved ones to COVID-19, that those pieces come together and create a higher likelihood that people will be overwhelmed with the life circumstances and feel like suicide is the only option for them. Importantly, however, with other major crises like 9/11, we actually saw a reduction in suicide. And the theory behind that is that at that point in time, people had an increased sense of belonging and increased shared social support immediately following the crisis. But we do know that things like unemployment, health problems, and incarcerations have been associated with suicide in the past. The theory being that people felt like they were a burden to their family, a burden to society. As I mentioned, COVID-19 and stress, kind of a perfect storm for suicide mortality. People are, especially in the very beginning of the pandemic, when everything went into social distancing and people were sheltering in place, people felt isolated and there was a disrupted sense of time because they weren't going to work or to school in the way that they usually did. People had a sense of loss of control and that everything was abnormal. I know in my family, we try to go for a walk once a day. And we would walk through the streets when it was still okay to walk. They were recommending that we be at home, but we weren't being ordered to stay in our homes. And it was bizarre to walk through the streets and see that they were so open and there weren't people there. Or you might have remembered going into a grocery store and seeing so many of the food aisles or toilet paper sections that were completely bare as people were buying up items. The media coverage has not helped at all with stress, especially for Asian American and Asian ancestry people with the racist tropes that have been out there about COVID-19. There's been quite a bit of misinformation. In the beginning, if you remember, they said, don't wear a mask. Now they're saying wear a mask. There was a question if bleach might be useful and any number of other pieces of misinformation that have been in the media. Of course, the recession causes economic stress, and there are distress reactions that are biologically that present themselves in people's ability to sleep, in people's disruption to their appetite, in disruption to a variety of different biological things that happen at a physical level. And then, of course, we're starting to see COVID-19 psychosis and other mental health issues that are following infection from COVID-19. They think this might be related to the inflammatory response in the brain, but there's also stress of like being in the ICU. We know prior to COVID-19 that being in ICU is very stressful, that we see what's called post-ICU syndrome, which are higher rates of PTSD and other anxieties. We're also seeing higher rates of increased rate of risk of suicide following COVID-19 pulmonary and cardiac outcomes. So prior to COVID-19, we knew that for people who have chronic pulmonary and cardiac crises, that there are higher rates of suicide. And because those things are also happening with COVID-19, we're thinking that there might be some expected elevated rates of suicide as well. Making the situation so much worse for people is that people are dying and grieving in isolation. So when people end up going to an ICU, they can't have family members with them. For those of us who have already lost family members, we have been challenged by not being able to have our burial services and other mourning practices. These can combine to create prolonged and complicated grief. We're seeing increased interpersonal violence, sexual abuse, and child abuse in homes. People who were engaging in these behaviors before the pandemic are now trapped at home with their family members and under even greater amounts of stress without having developed new coping strategies that are nonviolent. And it's especially of concern as the folks who are here, who are part of school mental health workforce, can very quickly tell us that youth are not being seen on a regular basis in the way that they were when they were in the physical environment of the school. So in a school environment, any number of people could have seen some warning signs that might have alerted somebody to call Child Protective Services, right? Could have been the teacher. It could have been the person who works in the school lunch line. It could have been the driver of the bus, any number of people. But right now, when we're in virtual school, oftentimes it's only one educator, maybe another who interacts with kids via Zoom. High school students at the end of this last year, by golly, what stress they faced by not being able to do the milestones of graduation ceremonies, of proms. And then here they are graduating and entering a job market during a recession. In fact, the American Psychological Association has been doing, sending out a report every year since 2007 that's called Stress in America. The 2020 Stress in America report, of course, focusing on COVID-19. But what they found is that Generation Z, these 13 to 23-year-olds, are expressing some of the highest levels of stress of the entire population in the United States. And it had to do with feeling like they were more isolated and detached from others, and also feeling like they were unable to plan for the future. The other population that they found had the highest levels of stress were parents who are juggling having children at home during virtual school, and if we're lucky enough to stay employed, also doing work from home. And those are two full-time jobs in and of themselves, of course. And then we think about the stress and trauma that our health professionals have experienced. For medical professionals, oftentimes explicitly or implicitly, the message is that if a patient dies, that their work was a failure. We've got clinicians who are working and living under extended crises. So they are having to work extended hours. They're also worried about coming home and whether or not they might infect their family members. They're working with colleagues who may have only completed part of their training to get to that moment. We're bringing people from the workforce who have already retired back in. And I saw somebody in the chat book said moral injury. Absolutely. Having worked with a veteran population, I am well aware that part of what's happening right now, and we're seeing this in the medical field, is this idea. Moral injury essentially means that something horrifying happens that challenges the very structure of beliefs that we were raised with. So good things happen to good people, bad things happen to bad people. And everything, when we have these ICUs that are overwhelmed and there's no place to take people who are gravely ill, suddenly people are having to make decisions about whose life is going to be saved over someone else. And that can lead to extreme moral injury. This is a lot. We're living through 2020 through a global pandemic together, and we're the mental health workforce. And I just want to acknowledge that this is a lot for so many of us. And so I want to take a moment and do a grounding break together. And so if you're comfortable with this, I would ask you to take one hand and put it on the top of your chest, and the other hand to put it at the top of your abdomen, right underneath your rib cage. And I'm going to lead you in a breathing exercise that I learned from a veteran. I think this actually comes from the Marine Corps. This is an exercise that I use sometimes myself throughout the day. This is an exercise that I've trained my 7-year-old to use at night when he feels stressed and he's having a hard time going to sleep. And this is absolutely an exercise that I used with all clients because it does not cost anything and you can do it just about anywhere. You can even do it on the bus. If you got a big jacket on, you put your hands underneath it and not be super visible. So what we're going to do is I'm going to ask you to imagine a box. And we're going to take a deep breath in for the count of 4, going up the side of the box. Then hold the breath for the count of 4 across the top of the box. Then slowly exhale to the count of 4, going down the side of the box. And then no breath back to the other side of the box at the bottom. Okay, so let's start together. If you want to, you may close your eyes. If you don't want to close your eyes, just gaze off into kind of like a soft gazing in somewhere else, not specific on anything. Okay, so we'll take a deep breath in. 1, 2, 3, 4. Hold it. 1, 2, 3, 4. Exhale slowly. 2, 3, 4. No breath. 2, 3, 4. Again, inhale. 2, 3, 4. Hold it. 2, 3, 4. Exhale. 2, 3, 4. No breath. 2, 3, 4. Last time. Slowly inhale. 2, 3, 4. Hold it. 2, 3, 4. Slowly exhale. 2, 3, 4. And no breath. 2, 3, 4. Thank you so much. I welcome you to put in the chat box how you're feeling. If that made any difference by slowing down your central nervous system, taking a moment and just focusing on the breath. I see Alexis saying, feeling calm. It works for me in the same way. And this, I think, is the important part of suicide prevention always. Suicide is typically a thought that comes on very strong, but it's time limited. might be a few minutes, it might be an hour, it might be a day or two, but it's time limited typically. And so if we can help people to just live through the extreme pain, fear, frustration, whatever that emotion is that feels so overwhelming that they can't cope, if we can just get them to get through that moment, there will be another emotion, a moment on the other side of this. I always tell people, no emotion is final. No feeling is final unless it's the very last emotion that we have in our lifetime. And I say that with people not in a way to shame anyone, but literally just to remind us that it does change. When we feel so overwhelmed and our central nervous system is sending all the messages with the cortisol stress hormones, it literally feels like this will never end. That's part of the way that our brains were created, was to make us feel like we are in danger and we've got to run and find some relief. And that's what a suicidal thought is. It is a sense of the brain creating a sense of a relief, a safety valve, if you will. So recognizing that so many of us are under significant amounts of stress as mental health providers, as just human beings, thank you very much, who are all living through a global pandemic, as well as taking care of others at work. And maybe we have families that we're taking care of, or friends as well. Here are resources for mental health providers. And these are all, again, in a resource guide that you have been sent and will send to you again. There are a variety of apps that are out there. This particular app was created by the National Center for Post-Traumatic Stress Disorder, which is part of the VA. It's a COVID coach app. And I think this is a really great app, in part because it helps us to track a variety of things that can get thrown off when our lives are disrupted by losing work, school, being at home, and so on. There are ways to track our mood, our anxiety level, our well-being, and we can set goals. So another audience poll, and just want to say, there's no right or wrong answer. This is just to try and gauge the level of depth that I should go into with explaining these two things to you. First one, how familiar are you with the SAMHSA 2020 National Guidelines for Behavioral Health Crisis Care, a best practice toolkit? Would you say you're not at all familiar? You never heard of it. Somewhat familiar. You may have glanced over it, but you could use a refresher. You're very familiar. Maybe you're even implementing it at work, or you're extremely familiar. You actually wrote the report yourself. 56% not familiar, have not read it. 38% somewhat familiar, but could use a refresher. Very familiar, implementing it at work. Wow. You know what, people? It just came out. It's amazing that any of you have even heard about it before. And I got to tell you, honestly, I feel a little bit relieved that none of the authors are actually in here, because I hope I do justice to them. So just saying that. So the next question is, how familiar are you with the SAMHSA 2020 Crisis Services Meeting Needs Saving Lives? Again, your answers to choose from are not at all familiar, have not read it, somewhat familiar, glanced over, but could use a refresher, very familiar, you're implementing at work, extremely familiar, you live and breathe this book. Not all familiar, have not read it. That makes complete sense. Guess what? It was just published, folks, December 2020. So hot off the presses. Next question. How familiar are you with the Zero Suicide Evidence-Based Actions Public Health Approach? Again, your choices are not at all familiar, never heard of it, somewhat familiar, glanced over, but could use a refresher, very familiar, implementing at work, extremely familiar. This puppy was my idea. 77% not at all familiar, 14% somewhat familiar. Great. Okay. Ooh, we have somebody who said the puppy was their idea. Well, thank you so much, because this is an excellent public health model. I'm so excited. If you want to identify yourselves in the chat box, we could all give a virtual round of applause, because it is a critically important public health approach to suicide prevention that's being adopted at a national level, a state level, county level. So thank you. And then finally, how familiar are you with the California Striving for Zero Suicide Prevention Strategic Plan for 2020-2025? Your answers to choose from. Not at all familiar. We have a state strategic plan for suicide prevention, ? Somewhat familiar, glanced over it, but could use a refresher. Very familiar, I'm implementing at work. Or extremely familiar, I teach this stuff in my sleep. Not at all familiar. We have a state level. What? This thing exists? Again, not all surprising, folks. It recently came out. That's great that we've got 2% who are already implementing it at work. Because of Zoom fatigue, I am trying to be careful with how much information I give you and which ways I give you. But briefly, suicide prevention can be thought about within a larger crisis continuum of care from a systems level by starting with the National Guidelines for Behavioral Health Crisis Care, a best practice toolkit from SAMHSA. This was recently published in 2020. And then SAMHSA got really fancy with us and they published it again and added a couple additional papers to it. But really the meat and potatoes of it is this guidelines for behavioral health crisis care. And what they're talking about is a systemic view. So as I mentioned previously, the goal is to reduce interventions that are not helpful, that are sometimes inhumane or lethal, and that are extremely costly to folks. So unnecessary hospitalizations, emergency room visits, engagement with law enforcement, and incarceration. When we think about suicide prevention, we're aiming to stay away from those and going more to more humane, effective types of treatment that are actually treatment. And so those include evidence-based practices like crisis lines and warm lines, mobile crisis units, crisis receiving and stabilization centers, ongoing community care like short-term residential care, peer respite, in-home therapy, community mental health clinics, and support for families. Importantly, what we are trying to do at any of those service levels is to de-escalate. So we want to address crisis where people feel the most comfortable. That's oftentimes in their home or in the community. It's not in an emergency room where there's all the stress and chaos that I mentioned before, or even in a locked psychiatric environment, which also can be very stressful. And you're separated from pets and loved ones and your favorite music and favorite pillow. And it's not a place that is really conducive to healing. We want to instill hope, and we can do that through anti-stigma approaches of peer specialists, peer support workers, people with lived experience. Importantly here, there's an idea that there's no wrong door, that any place where a person shows up with mental health crisis and suicidality, that they're going to receive help. This is especially important when we think about men in America. Men in America overwhelmingly who are having suicidal thoughts or experiences are interacted with first in an emergency room. It's not typically in mental health clinics or other places. And part of that has to do with socialization of gender and the ideas of, is it okay to ask for help? Is it okay to acknowledge that a man is actually feeling intense feelings? Because the stereotype of manhood, of course, is that men don't feel these things. And we know that's not the case. Also critically important, that warm handoff, what I was mentioning before. It's not just so that the person who works at the community-based clinic and who interacts with their client and the client says that they're having suicidal thoughts and they're assessed to be at high risk, sends the person over to an emergency room, but actually making sure, did the person make it there? If that's the option, because there's an imminent risk involved. If it's somebody who works on an inpatient psychiatric unit and they're working with a client who's about to be discharged and they make the referral to community-based support afterward, checking to see, did that person actually connect with somebody at the community-based clinic? Right now in COVID-19 world, is that clinic even open? When they get out of the hospital and they get back into the community, is there any door that's literally going to be open to them? But it's even more than that. It's checking to see that the connection was actually made and that it was a connection that was a strong connection that the client feels like they actually want to engage with again. The idea of air traffic control is really, really important. So when we think about the ideas of a mobile crisis unit, for example, which is called as an alternative to 911, mobile crisis unit is called, they're sent out to the person's home. They need to know very quickly if that person needs immediate help, where there might be a bed, or if it's a brief psychiatric stabilization unit, where there might be a recliner chair, essentially, that's available for that client. They need to be able to know that they're not going to send somebody to sit in a waiting room for 30 minutes to 5 hours. Thank you very much. Because what's more stressful than to sit in the waiting room of anywhere, but especially an emergency room? So air traffic control is a system that's literally used by the airline industry to, through the use of real-time data and technology, know where are there barriers to the system flowing well. You know, where do we see that there are beds that are available that are not being used? Where are people running into barriers that's preventing them from making it to the next part in that system? And then, as I mentioned, ongoing follow-up care. In fact, in several studies, but especially one that was completed with veterans at Veterans Affairs Hospital, there was a reduction by almost 50% in suicide among veterans who received engagement in a safety plan while they were in the emergency room, and they had follow-up contact. I cannot express enough how important it is to receive a phone call or receive a card in the mail, any kind of, or text message if people have approvals, and everyone's agreed to and HIPAA compliant text messaging that says, hey, I heard you got home from the brief psychiatric hospital unit or other facility. How are you doing? Checking in like that makes a huge difference. And it's important because we do see elevated rates of suicide after people are discharged from psychiatric units. So importantly, I've mentioned this, I won't go into it too much, but the crisis continuum of care, when we think about suicide crisis care, specifically, we've got to be using our evidence-based practices. So importantly, and when we think about relapse and preventing suicide crisis relapse, it's really important that we have identified the unmet needs and that we're actually going to address them. And that's part of what we're going to walk through with the suicide safety plan. But importantly, it's not just what you and I do in our individual interactions with a client or a consumer or community member. It's stepping back and saying, okay, now I'm doing the systematic assessments with every client that I work with, and I'm doing the safety plan. But I need to step back and ask my agency and all the other agencies that my client might interact with, whether or not we have protocols and plans in place to make sure that there are warm handoffs across the system, that people are being followed up on, that nobody is dropped through a crack or a fissure in the system, if it were. It also includes things like making sure that we're not asking our clients to retell their trauma stories over and over and over again in all these different systems. So it's a matter of making sure that we're communicating with the next system that's going to interact with that client and sharing all the information that we possibly can. We really, of course, always want to make sure that we're identifying the least restrictive option and that people are being treated in safe, dignified, and trauma-informed ways. Zero Suicide, we've got an author on this call with us. Thank you, thank you, thank you again. It's a profoundly beautiful public health approach to suicide prevention, evidence-based. It is really talking about culture change in agencies and society at large. It's talking about the importance of making sure that we are systematically assessing suicide risk with every client that we work with at some point during our work with them. As you'll see, if we're working with patients over telehealth, I recommend, and I'm seeing it in the literature as well, especially right now, that we do a very brief suicide assessment and every single time that we talk to people, by telephone, by Zoom, however it is. But we have to make sure that it's systematic. We have to make sure that if people are being identified through a suicide screening tool as being at risk, that we're connecting them to the appropriate level of support based on their level of risk. We have to make sure that we're documenting all of this work that we're doing, and that there is a feedback system so that we're checking to see, okay, this was our goal initially. Are we actually doing this? Now, the only way to make sure that this happens is to ensure that we're training all of our staff. So part of our employee orientation should include suicide prevention. There should be suicide prevention intervention training for all staff at least once a year. We need to make sure that this is mandated, that it's coordinated, and that it's automated. So when I was at Veterans Affairs, one of the really exciting things that they did was creating templates of the suicide screening tools that we used. And so in order to check the box that I've done the suicide screening, I have to literally use the suicide screening tool that's evidence-based, not just asking people off the top of my head a question that may or may not be the most effective in identifying potential suicide risk. So I think I promised you something exciting, and this is it. And thank you. If there's any MHS, OAC folks on the call, they have put together a transparency suite for us. If you were to click on this link, and you've got the slides, we'll send them to you again, you can go to what's called a transparency suite, where you can search by your county to figure out what crisis care continuum services are available. You might see that you have a crisis prevention hotline you didn't know about, or crisis services, crisis stabilization unit, the mobile crisis teams, or even suicide prevention programs. And it's important to note that that data is 2018 to 2019. And what I just showed you is not exhaustive list because that data is collected by the counties reporting out to the state what programs they have. And there's still a lot of variance in the terms that we're using for the same kind of service. So in my quick search of the data, I may not have captured all of those services that are actually available. Okay, we've got a poll here. Have you ever conducted or done suicide prevention over telehealth? Yes or no? So 78% have said no, thank you. And I'm seeing someone saying it's so nerve-wracking. Well, guess what, folks? I am thrilled to share with you that this is like riding a bicycle is my experience. It is totally nerve-wracking. You're dealing with technology. You're dealing with not necessarily knowing where the person is located. And in COVID-19 world, you're dealing with is the place that I would refer them to even open? There are so many different things that one can think about. I would encourage all of us to check out at the bottom here, and I sent it to you, or Stephen, excuse me, thank you, Stephen, sent it to you, telehealth clinical and technical considerations for mental health providers. I wrote this with several colleagues at the beginning of the pandemic, and it's talking not just about how to use telehealth, but how to do it in the social distance world that we're in. And there's a big section on suicide prevention. So briefly, here's what I recommend. And the literature, I didn't come up with this stuff, frankly, I'm citing others, but here's what they say. Every single session, you want to ask the person first and foremost, where are you right now? Because if there's a crisis, you need to know who it is that you're going to connect them with. You want to make sure that you have at hand the local crisis information that you would need for where that person is at. And that's, again, why you'd go back to that transparency suite that I mentioned on that previous slide. Good idea, write down these phone numbers on a piece of paper. So in case your power goes out, you're not at a loss. You're going to want to explain to your clients that there is a crisis management and loss connection protocol. So if suddenly they lose internet connection or you lose internet connection, that you're going to call them and they need to answer the phone. And if they don't answer the phone, it's not like when you meet face to face. You meet and look, when I was a clinician in an office, I could have Joe Schmo, my client, for example, get really ticked off at me. Maybe I was pushing a little too hard. That might have happened. And the person storms out of my office, right? I can follow that person into the parking lot to figure out if they're actually in crisis of imminent risk or not. In telehealth, if they suddenly shut down their camera and they refuse to answer the phone, I don't know why that's happened. I have to assume that there's the highest risk possible. And they need to know that at that point, I'm going to be calling a crisis line, or I'm going to be calling a warm line or something like that. And then we want to conduct a risk assessment. They only take a matter of moments. It's really important to do this. I would say every time that you meet with somebody over telehealth. And importantly, you want to document the assessment and the safety plan. In the safety plan, there is going to be, we're recommending that person identify a support person for them. And we want to write that person on the safety plan. And this is the information that I recommend giving that support person, of course, with your client's written permission through a release of information. The psychological emotional first aid app, which is later on in the slides, Now Matters Now website, NAMI websites. This is information that's created for lay people. That is people who are not necessarily coming from a mental health background so that they can support their loved ones, family members, friends, whoever it might be that they have agreed to be a support person for. You want to clarify to that support person, you can contact me, but I am not emergency services. So you need to give them the line for crisis lines or warm lines that are local and also 911. So the bird's eye view of suicidal crisis, and I'm sorry, we don't have enough time for me to show you this really awesome video that explains when people have repeated suicidal thoughts, how that works from a dialectical behavioral therapy perspective, but I really encourage you to check it out later. As I said before, suicidal crises are typically time limited, and it's a matter of helping the person get through that moment. When the brain releases cortisol, stress hormone, it's important to know that the body can absorb it within 2 to 4 minutes, literally. So one of the big things that we can do is anything to help the person stay calm and stay still for 2 to 4 minutes. And if someone's living with PTSD, for example, and they're in, IKEA, like what a place to be when you have stressors about being overly stimulated by everything else going on. A lot of people, veterans that I've worked with who live with PTSD, they hated IKEA, or they hated like big shopping centers where there was too much going on. So sometimes they would be activated in that environment. We always would recommend go to the opposite kind of an environment. you're feeling activated in this super intense space, then go somewhere open and quiet. Help your body to do whatever the opposite is of what it's doing in that moment. So oftentimes people will have increased heart rate. They'll be breathing kind of hard. They might be clenching their fists. So then we would encourage them to do some of that box breathing that I shared, or to intentionally relax every muscle in their body. Oftentimes, if you can get through that 2 to 4 minutes, the body will have started to absorb the cortisol and they will physiologically feel different. And then, of course, that we want to have problem-solving skills that people can actually use and access to support resources. So there are a variety of suicide screening tools that are evidence-based that are out there. If you happen to work at a hospital or a community center that goes through Joint Commission accreditation, you'll know that Joint Commission has a variety of tools that they recommend. Just 2 of them are the ASQ Suicide Screening Toolkit for the National Institute of Mental Health, as well as the Columbia Suicide Severity Rating Scale. In that resource guide that I've provided you, I've given you the links to these safety plans, as well as the screening tools. And there are even links to videos where you can learn how to use the screening tool if you've never used it before. So importantly, this ASK tool is especially developed to work with young people. So if you work with youth, this is a great tool to use for that reason as well. And then you probably, if you haven't seen these before, the bottom of the tools, they also have crisis lines and information that you can engage if people are rated at being moderate to high level of risk. So polling question, do suicide contracts work? So do suicide contracts reduce the incidence of suicide? That a suicide contract, if you're not familiar, is asking that the client promise you not to hurt themselves. Does that work? Answer is 53% say no, 47% say yes. In fact, if you take any one thing from this presentation from me, please take this point of information. Suicide contracts do not work. In fact, they are anti-therapeutic. Many clients will feel that a clinician is asking them to promise not to injure themselves because the clinician is focused on their own liability. They'll take it as you only care about how you're doing and whether or not you might get sued. And anyway, the problem that I'm dealing with is so significant that, like, if I am overwhelmed with pain, anger, grief, loss, in that moment, the motivation to keep my promise to you is nothing compared with my need to resolve the difficult feelings that I'm experiencing right now. So actually, when we ask clients to promise not to hurt themselves, we oftentimes can lose rapport with them that we might have developed, and it's not effective. What is effective are safety plans. And the reason why safety plans are effective are because they help people to actually identify things that are activating for them, people who can help them, activities that can help to get through that moment, often, as I said before, brief, limited time period, and are explicitly sharing where people can get support from a system if needed. They should be written in I language. So rather than, if you're doing a safety plan with someone, rather than saying Joe Schmo says blah, 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 it's actually written in the client or patient's own voice because it's their safety plan. If they have to use it, they need it to be like it's written from them, not from you. So when we think about culturally specific safety plans, and I've talked about this a little bit earlier, we want to identify the culturally specific risks. So what are the things that are major stressors? For example, we see that with many Asian ancestry populations, the major emotion that happens right before a suicide attempt is not depression. It's actually shame. So we want to look at what are the things that can happen, life events, and what are the feelings that a culture says are unacceptable and intolerable. Additionally, we want to try and think about what does this culture, and maybe it's a religious or spiritual culture as well, right? What does this culture say about people who make the decision to attempt suicide or to engage in suicidal behaviors? We want to build on the cultural strengths and affirming histories of people. And we can think about things like blues music, sweat lodges, a variety of different activities that involve music, culture, prayer, that instill a sense of hope, that speak truth to power and speak authentically about pain as well. Hip hop is, and critically conscious hip hop, especially, I think this is why I got into it so many years ago, is because it says it out loud. It says the thing that is so painful. Culturally specific suicide prevention acknowledges that there is systemic racism, sexism, homophobia, transphobia that result in these intolerable experiences of pain. And that lack of access to mental health care and the pipeline to incarceration disproportionately impact some of our communities. And that's related to us feeling like we can't get through or tolerate the overwhelming emotions. And critically important transformative healing practices are about unlearning our internalized isms. And this can also especially happen through storytelling. And this is, again, why our peer specialists are so key and critical. And that we have to advocate to end the isms, racism, sexism, homophobia that are within our mental health systems, because those mental health systems can at times injure our clients. So this is just one of many safety plans. This is Stanley et al., who are very heavily cited in literature. We know that this safety plan, which is a very basic safety plan, works with a variety of different populations. This is another safety plan that's created by the Now Matters Now website, which is a website I highly recommend you going to it and sharing it with your clients as well. People with lived experience of suicide have created this website. They have videos, first-person accounts of what they're doing now to help themselves get through those recurring thoughts about suicidal ideation. And this is a safety plan that they've created as well. So we're going to take just a few minutes to actually act out a safety plan for you. I am thrilled to invite to join us my esteemed colleague, Tiara Peterkin. Tiara is a licensed clinical social worker, and she's also the program manager for the CARE TA Center. And Tiara, welcome. So nice to see you.
Thank you. Hey.
So in this scenario, I'm going to pretend to be Tiara's therapist. And Tiara, would you please get into character and tell us a little bit about who you are, please?
So my name is Ray. I'm 27, and I am struggling with suicidal urges. So that's sort of the client I want you guys to think about. And here's my story. So I'm Ray. I've been sober for 3 years, but recently broke up with my girlfriend. I'd previously been okay and was stable. During that time, I was going to NA 4 times a week. I was going to church, also going to the beach 2 to 3 times a week. I love to play pool every day. But now things are shut down and I don't have any of my go-tos, anything I've been used to that helped me with that stability. The breakup started hitting me hard, and now I started drinking. That obviously is a relapse from my sober days. I'm using alcohol, marijuana several times a day, every day. And I just don't know how I'm gonna get through this situation. I've had suicidal thoughts come up a little more frequently lately. And as some of those thoughts have led to plans, in fact, and I've considered jumping off a freeway overpass here in LA. I don't think you can help me in talking to my therapist. I felt this poorly before, and here I am.
Ray, thank you. Thank you so much for being here today. And thank you for having completed the suicide risk assessment with me. We do this every week that we meet together over telehealth. And as you just mentioned, we noticed that the thoughts are getting more intense. And there's actually a plan now. And this is different, that in past weeks, you thought that there were kind of like fleeting thoughts here and there about feeling overwhelmed. But now this is the first time that you've actually talked about a means, which is the overpass. So with your permission, I'd like to do a safety plan with you. And a safety plan is, it's a tool that we use that we know can really help people in the moments when they become overwhelmed. And you might remember that we did a safety plan when we first started working together.
Sure. Yeah.
Things have changed a lot since then. Now in COVID-19 and social distancing world, it's a good time for us to step back and kind of look at that safety plan together to figure out, if we need to change any of the resources that are involved. So let's go back first and start off with our safety plan. Ray, I'm going to use a safety plan where we're going to first start off talking about warning signs. Then we're going to talk about any internal coping strategies. That's things that you can do to help yourself in those moments when you feel overwhelmed.
Okay.
Then we're going to talk about people and social settings that can provide a distraction. And then we're going to talk about people who you can actually ask for help from. Finally, professionals or agencies that you can ask for help from during a crisis. And then what we can do to help make your environment safer. Does that sound okay?
If you think it'll help. Okay.
So the first thing is the warning signs. So can you tell me, Ray, when the thoughts about the overpass become really intense, what are the thoughts that are happening before that comes up? Like any feelings you might have or situations?
I just start to feel really alone. I just broke up with my girlfriend, and like we always had dinner together. So like around dinner time, and I start to feel alone, and I know there's a lot of traffic and rush hour by the freeway. So just that's how the thought comes up.
That feeling of aloneness and that specific time period, that is such an astute point that you have that awareness of yourself, that there's a specific time of day when that happens. And I am so sorry. The process of going through a breakup is excruciatingly painful. And I really appreciate you being willing to talk about this with me. Are there any other things that happen, experiences or moods that you notice are right before that thought comes up for you?
Just feel depressed and alone. Yeah.
Okay. So feeling alone and depressed. And in your daily life, is there anything that makes you feel more depressed or more aware of the depression?
Not that I can think of.
Okay. So you've talked about a time of day that was located with dinner because you typically had dinner with your girlfriend.
Right.
When you think about the depression, do you have more of a feeling about this in the morning or in the evening or afternoon? Sometimes people will feel tired or they'll feel energized, and that sometimes can relate.
No, it just, it just sucks that we broke up, and I just get really sad when I start to think about it. But usually during the day, I'm drinking, but dinner time, I can't distract myself as much as I like. So
that's a really important point that you just brought up around the drinking. What time during the day do you on average start drinking?
I sleep in, so I don't know if that's right when I wake up, but like in the afternoon, after lunch, I usually start drinking.
Okay.
I like to drink beer.
Okay. Drinking beer, afternoon. Okay. And are you using any marijuana at this point?
Yeah, I started using marijuana as well.
In the
Just
past,
hand in hand.
Hand in hand. The two go together.
Yeah.
Okay. In the past, when you've used marijuana, have you talked about it causing some feelings of anxiety, like feeling a little bit anxious and kind of jittery, a little paranoid? Are you noticing that happening at this period of your life?
Somewhat.
So I'm hearing and I'm writing down here feelings of aloneness, depression, and when marijuana and alcohol are used, sometimes it's also feelings of anxiety. Is that an accurate reflection? Okay. So now I want to step back and think about some internal coping strategies. That's things that you can do to help yourself with those feelings when they come up. It might be things that you can do to get your mind off of the sadness and the aloneness that you feel with this breakup, or to prevent also some of the feelings of anxiousness and depression.
Well, I can't play pool anymore. It's shut down. That was my thing. So I don't know if there's anything I can do.
I remember you talking about going to billiards, and it was really, what I remember you saying, it was a really important place, not just because you're really good at playing pool, a little bit of a shark, if I might, but also it was an important place where you were able to connect with other people.
Mm-hmm, mm-hmm.
So I'm imagining that part of what you're missing is not just the actual game of playing pool, but it's that social interaction.
Definitely.
Okay. It's hard. Social distancing.
Right.
I think before we've talked about the fact that you and I both have Comcast service. I don't know if you've ever seen Comcast. There's actually games online that you can play with your remote. I've started doing, I'm serious. I've started doing bowling. It's a big deal in my house and you can bowl. So I don't know if it's available, but I would kind of check that out perhaps about, what kinds of gaming might be available either through your television or through your computer. And if you'd be open to it, I'd be happy to share with you some resources that are online games that you can still not only kind of flex your gaming muscle, if you will, but also to connect with other people. You can play these games with other people that you've never met, or you can bring your friends in to play them online as well.
Wow.
Does that sound like something you might be willing to give a try?
Yeah, I never heard of those resources. That sounds pretty cool. Yes, please.
So we can put that there. Now, I remember you also used to go to church a lot, and that was really important for you.
Yeah.
Is your church open these days?
No, well, it changes. Sometimes they're open, but there's a lot of people in there. I don't feel comfortable going. So I don't go anymore, and I can't seem to connect, spiritually though, because every Sunday is really helpful, but now I just don't go.
And if I remember correctly, you're Baptist. Is that correct?
Yes.
Okay. So I'm wondering if there might be, and I know it's different, but I've seen in town that there are some churches that are and other places of worship that are having services outside. And so people are able to have some social distancing, but they're still able to participate in community. And I've also seen my mom, for example, attends a church online. And again, it is different because she's not able to receive communion in the same way that in person, but for her, it's a Catholic church, and that priest has actually changed some of the service so that it can be done remotely. So that also might be something that we could look into together if you'd be open to it.
I didn't know they had outside service. I would go to that. At least then I could kind of be around people. I haven't really engaged with people socially very much at all in the last couple months.
And it's been so hard when the regulations change. Like at a certain point, we have to stay at home, and other times they let us out of our homes, but only in certain situations. So all of these resources that I'm going to send you, we'd have to kind of check before even trying them out if they're still available. I want to back up for 1 second that I know it's been really important. You've talked about over our time together, connecting with other Black lesbians. Are you finding that right now not having that connection is as a challenge?
Yeah, it's so hard. I used to go to West Hollywood is an area of town where it's kind of reliable to find that kind of community, and things are just shut down, so it's not the same.
I don't know if you've heard about them, but there are two agencies in particular that I've been really impressed with their work on. The first is Sisters Mentally Mobilized, who have gone virtual. So these are Black women support groups. And I first heard about it from somebody who identifies as lesbian. So I don't know if she's out in that space or not, but if you'd like, I could ask her the extent to which she feels like it's a safe place for a lesbian to participate.
That would be great. That would be great. Yeah.
Okay. I'm just writing this information down on the safety plan here. The other thing that I'd like to share with you, and this is an agency that I have such respect for and appreciation because they fill a major role in the community. They're called BEAM, Black Emotional and Mental Health Intelligence. I'm sorry, BEAM, BEAM. I'm going to look it up to make sure that I'm not messing up this acronym. But essentially, I know that they're an LGBTQ plus open and affirming agency. They have created a really powerful list of licensed providers and non-licensed providers who are Black professionals who are providing services to the community. So it's like teletherapy. It's just a variety of different kinds of resources. And that might be another place to connect. I know that the folks that I first interacted with through there are Black gay men, but I know that they also have specific groups for trans folk. I would wonder if they also might have some specific groups for lesbian women as well.
Yeah, any kind of online group, that would be, there's so much available. I was feeling really alone. I had no idea that there was a way to connect with people like this. It's just good information.
I'm seeing that we're at the end of our time here, but the next couple of things that I would be doing with you, I'm going to break out of character. The next couple of things that I would be doing with a client would be to help them to identify people that they can call up who they don't say that they're in a crisis with, but just like a friend who they can get on the phone and just kind of like talk. And then I would encourage the client to think about people that they can call and say, I'm actually having a rough time right now. Can you help me out? And then finally, I would go into the list of professionals or agencies that the person can contact, making sure that they're actually open and available right now, and asking the client whether or not I have permission to communicate with them, because that's the other side of this crisis continuum of care systems approach. I need to be able to communicate back and forth, sharing client information, checking to see follow through has happened and so on. And then finally, making the environment safe. Now with Ray, it's going to be a little bit more challenging because it's not like a gun, and we could talk about gun safes and we could talk about gun locks. Or if it was a thought or plan around medications, we could talk about safe storage of medications. But because it's a bridge, instead I would be thinking about that time of day, because she specifically mentioned traffic. So trying to come up with some activities and ideas that would automatically flow at that time of day that would keep her away from the bridge. So very briefly, I just want to say a huge thank you, Tiara, for participating in this. It's really, really appreciated. The good news for you all is that everything that's from here on out in these slides are resources that are listed in the resource list that was specifically created to be an electronic resource. So you can just click on the hyperlinks. We'll go to all the way to the end of the slides, please. I want to make sure that people know that we have a variety of resources that are not just in the resource library or the resource document that I just mentioned, but also I've got the references here in the slides, and we've got several upcoming trainings that we are excited for you to participate in. And without further ado, I just really thank everyone so much for being here. Here's our contact information. We hope that you'll be in contact with us, and do feel free to please share your thoughts with us in the evaluation form as well as in our needs assessment.
Eliana?
Yes.
I want to ask you really quickly. We have one question that hadn't been addressed is, what would you say the best routine suicide risk screen is for to use for every patient or client? Do you have a best?
I do. I really like the Columbia Suicide Severity Rating Scale, CSSRS. If you go to that resource guide that I put together, they're on their CSSRS website. They talk about different populations that you can use the screening tool with. And it's also validated and been tested with telehealth. And thank you all so much for the work you do. I failed to say this in the beginning, but as somebody who has lived experience and somebody who has lost friends and clients, this is really very difficult, intense, and extremely important work that we're all doing. And so I just want to honor you all in the fact that you do the work that you do and that you would show up to a session like this. I really appreciate you.